Good morning, all. Welcome to day 3. We're just going to wait a few minutes. There's a few more people just kind of getting through the waiting room, and we'll crack on. Right then. So welcome to Friday, day 3. Just going to share a presentation with your good selves. Excellent. We very much appreciate there'll be some people joining in. This is day 3. I'm Dr. Paddy Morgan. I work with the Extreme Environments Laboratory in Portsmouth, but I'm also an anaesthetist, some bits with HEMS and some work with UK Search and Rescue with the Coast Guard. But I'm not here as a main event today. I'm merely here to chair the meeting, if you like. We've got some excellent presentations lined up for the rest of the day, but no pressure. We've had 2 days of excellent work so far. If we take a journey back to when we started on day 1, we talked about the process, the patient's pathway, the victim's journey through drowning. Now, if you then look at the timeline and we look at how we can prepare, prevent, react, and mitigate, we've had presentations in days 1 and 2 that have touched on all of these areas, and it continues again today. We've got front-end clinicians looking at ultrasound in the emergency department. We've got prevention strategies in floating. We've got people looking at the use of AEDs, as well as some very hardcore science looking at the evidence around particular interventions in the clinical world. But all of this, I want you to, as participants, to think about this and say, well, how is that going to affect my role? How is that going to change what I do or amend something? Or what questions is that raising that I need to go and have a quick look at? Because at the end of the day, we are all part of this chain, this timeline, this patient's journey in some way, shape, or form. So, and I've stolen this unashamedly from Justin Semsprott, who talked about low middle income countries and climate change and how that's actually affecting the drowning problem. And he said, oh, the key is to normalize, to localize a problem, and then collaborate. Now, if I could emphasize here, collaboration is the key. One person can't do all of the work that is required to prevent and treat drowning. But if we work together, potentially, we can get that a little bit closer. And we're never going to stop drownings, but what we can do is reduce it significantly. And if they do occur, reduce that burden of that mortality, morbidity that can occur. When we look at the map of the world, this is our home. I mean, planet Earth is where we live. It's where we play. Many of us are water persons, surfers, swimmers, divers, lifeguards, or just actually like looking out over the lakes, kayaking in the rivers. But this is our planet. It's getting warmer. So climate change is a real problem, and we need to actually be looking at how is that impacting on our lives, but also those around us in our countries and then worldwide. How do we then reduce the climate change problem, which then in turn will reduce our drowning problem? Drowning is also that global problem as well. And if we look at it, we've got 38 countries are registered for the conference. We've got participants in excess of 300. Between us, that's quite a powerful team. You know, good number of people representing a lot of nations, high income, middle income, low income, good strategies, learning strategies, just dipping the toe in the water, pardoning the pun. But this is a quote from one of our Twitter feeds, deciding not to play, that it is a bit like the Avengers. Now, other superheroes are available, but this is a call to you guys. As the Avengers assembling, no, it's dead. There you go. It's the scene in Avengers where they all go, Avengers, assemble! You'll get the gist. I'm calling upon yourselves, you know, which Avenger are you? Now, don't get me wrong, I'm not Captain America. I think he's sat to my right-hand side. But it doesn't matter. The key is that it doesn't take one person. It's a team effort. It's collaboration. It's looking at that patient journey from start to finish and seeing which bits we can make a difference to. We've got some excellent presentations lined up for today. As always, this wouldn't happen again on our own. So a big thank you to the Physiological Society and IDRA as supporters of this project. And in particular, Sarah, Simon and Caitlin, who have basically been the engine in the background. Many of you will have been admitted by Simon if we can't get there quick enough. He's essentially making it all flow beautifully in the background. And again, to my co-organising committee, Adi Mayhew, Mike Tipton and Jenny Smith.
Thank you. Thank you for the invitation. And I must be honest, I saw this event advertised. I've not done hardcore science on the utility of point-of-care ultrasound in drowning resuscitation, but I think it is a really unique opportunity to discuss this, because point-of-care ultrasound is everywhere. I wear this today. I'm working today, this stethoscope. But I'm not really using it that much, and especially not in diagnosing respiratory failure. And that's one of the things that we're going to talk about today. So we'll talk a little bit first, what is point-of-care ultrasound? Because then maybe this audience is not only consistent of medical professionals. So we know we use ultrasound for pregnancy. We use ultrasound to look at the heart, people with heart disease. But nowadays we use point-of-care ultrasound more as a complementary to a medical examination. Like we use our hands, like we use a stethoscope. We're trying to find out some early details, what could be wrong with this patient. It's something that we can repeat. It is non-invasive. We can use it in a pre-hospital care environment, though it does need training. And most of all, you need to really understand what's going on in front of you. What is going on with this patient? You don't have anything with only ultrasound findings. You really need to understand what's happening with the patient. I think that's specific in a drowning victim, really important. The picture here I think in 1718, they developed the first stethoscope. And we're still using that. And the evidence, we know in pneumonia and heart failure that ultrasound is far superior. And so should we use ultrasound to detect an alveolar interstitial syndrome in drowning victim, or any insult to the lungs? Should we use ultrasound? Now, when we use lung ultrasound, this is what you would see. We call it as a bad sign. We look at the visceral and the peritoneal pleura, and we can see the artifacts of the structures there below, and we see horizontal lines that we call A lines. This is a normal lung. I don't want to go too much in details on the technical part. I think it's more interesting to have a shared discussion what the utility could be. We use normally a blue protocol, the same thing as we use the stethoscope. We put it on different areas of the chest to detect any abnormalities. Now, this is an abnormal lung ultrasound that would be suggestive for an alveolar syndrome, or like someone with ARDS, also a severe drowning victim. We can see vertical lines going down. We don't see the horizontal lines. This would be pretty bad, probably. There is as I said earlier, there's very limited data yet, though we know that in a lot of places, people use a lot of lung ultrasound, but there's not a lot of science and data yet. And therefore, I think it's great that we have this meeting. And I invite everyone to collect more data if you use ultrasound in drowning victims. And hopefully we can come up with a study that we can do a bit more rigorous research. The drown rule out with novices is probably the only study that's been done so far in the States. And there's very limited numbers, but they did realize that it's pretty sensitive and specific to use ultrasound in drowning victims. So why should we use it? I think the main thing, this is a different diagnostic approach to respiratory failure of the drowning victim. We can monitor the evolution of the respiratory disorder. We can optimize ventilation and circulation. And then we can also early detect and manage complications. In a really sick drowning victim, we often need to give high pressures, and that can lead to complications. And there is no point-of-care ultrasound is everywhere. Besides the first 4 points, any medical student nowadays, they don't learn auscultation that well. They learn lung ultrasound, they learn echocardiography. And so we need to also adapt to a new climate, I think, and understand that it is happening. And so if we go to the severity grading of drowning, we we have included their abnormal lung sounds. And so it's mainly based on auscultation. Now, I think if we all be honest, if we look at a sick drowning victim, we don't only use our stethoscope. We use the holistic approach and look at the patient more in completion. Look at the work of breathing, look actually what happened, look at saturation. So auscultation is definitely not the only thing that we make our decisions on, but it is included in main algorithms. So, you know, should we use ultrasound to understand better what's actually happening to this drowning victim? Especially in grade 3 patients, are we able to detect actually better than X-ray findings? And now we can able to detect this early in a pre-hospital setting. So in the grade 2 patients, we and the transition to grade 3, you know, we might pick up changes, and we can see the vertical lines in this ultrasound suggestive that there is a lung insult there. In grade 4, we have more confluent, we call them B lines, and some irregular pleura here that is suggestive that the condition is getting worse, or this patient is maybe clinically worse. Now, what is the signature, the sonographic signature of the drowning victim? You know, they can aspirate, they can develop ARDS or an acute lung injury. They may have atelectasis when ventilating. They may get secondary pneumonia. They get infusions. They can get cardiovascular compromise, and maybe have an initial insult that was cardiac and have cardiogenic pulmonary edema. They can get a barotrauma. So there's lots of utilities what we can look at. Again, we also need to describe this. What is the signature, sonographic signature of a drowning victim? So I think we need to write this down. And I'm in the process to set up a study or to look into this and to make people more aware what we can expect and collect more data. So we have here like a picture of a bit more zoomed in on the pleura. We see there's a bit of irregular pleura. The white line is the pleura and vertical B lines. Now we can develop ARDS, an acute lung injury in the severe drowning victim. There we see more irregular thickened pleura with subpleural and posterior consolidation. In some ICU settings, there will be a long score derived from this from these images, and we can look at severity. With the coming of our AI and ultrasound that is coming more and more in, that we actually can accurately count the amount of B lines and the amount of lung findings. This might be also something what we need to look out for, but more research needs to be done. In an ICU setting, they calculate a lung score at the moment. I don't think that's particularly helpful in a pre-hospital setting or in an emergency department, because we don't really have time for that probably. The other thing we can see is a shred sign of consolidation, and dynamic air bronchograms, suggestive for potentially pneumonia. And so what are the research gaps using point of care ultrasound in a drowning victim? So I think, severity grading, understanding how the sonographic signature looks like, the trajectory of patients on ultrasound, and looking at what's the access to focus, because drowning happens in low-income countries. Do they have point of care ultrasound? We probably know that there's less access, but the access to point of care ultrasound is also growing, and especially in low resource settings, because they don't have access to CTs, they might get more and more point of care ultrasounds as well. If we see recent events in Libya and ongoing issues in the Mediterranean with multi-casualty, is lung ultrasound in a pre-hospital setting useful to identify which patients you want to evacuate early if you have multiple casualties. So there's lots of work to be done. We do a lot of lung ultrasounds already, but we've not really described it well what the role is in drowning victims, and we need to start doing that. And I'm interested if other people use point of care ultrasound, have used it in drowning victims in the audience at the moment. And I'm really happy to be contacted if people are interested to collaborate on more research. So that was my talk. It was pretty brief. I didn't know how much detail I wanted to go on the technical part, but I think the last slide is the most interesting, and I'll open it up to the audience if there's any people want to comment.
Hello everyone, my name's Dominic. I'm a military doctor working in diving and hyperbaric medicine for the British Royal Navy. I'm going to talk about some of our thoughts about how we can use AEDs in a military as well as occupational diving context. The background of this is currently we deploy AEDs to some of our dive teams, but not all of them. And we were looking at the risks and benefits of deploying them more broadly. So I'm going to start by talking about what guidelines and evidence there is available about the use of AEDs in drowning, and then how this can be applied to the occupational diving context, both looking at the specific maritime environment we work in and how our populations will differ, a population of divers from an undifferentiated population. We're going to identify some potential risks in bringing in AEDs into our environment, and talk about what we can do, what we think we can do to mitigate these risks. So firstly, I've had a look through all the guidance available, and there's quite a variety from Australian New Zealand Committee on Resuscitation, B&J Best Practice, Wilderness Medicine, and more. All this advice lies on a spectrum from you should apply an AED once it's available to you can consider applying an AED. And in terms of benefits, they will either say that it may be beneficial or it's unlikely to be beneficial, or somewhere along the way. The advice does all generally suggest that applying the AED should not be prioritized over good quality CPR, in particular ventilation and oxygenation to correct hypoxia. But in general, there's sort of quite a lot of flexibility in these guidelines. So with looking at evidence from scoping reviews by Behrens et al., we expect between 2 and 14% of an undifferentiated population of drowning casualties in cardiac arrest to present with a shockable rhythm. Now, unfortunately, I couldn't identify any papers specifically, either interventional observational papers specifically looking at the use of AEDs in drowning casualties. There is one recent Japanese study looking at AEDs in cardiac arrests of non-cardiac etiology, but they weren't able to identify a significant benefit in patients who'd received an initial shock from an AED, but this is likely because of their small sample size, where only 57 patients received an out-of-hospital AED shock compared to about 1,000 who had an EMS shock pre-hospital. Moving on to the maritime environment, their studies have demonstrated that lifeguards are able to provide chest compressions on sort of small water-based craft, but that these chest compressions tend to be of lower quality than land-based chest compressions. And more recently, studies have looked at using mechanical chest compression devices and shown that actually mechanical chest compression may be better quality than manual chest compressions when on a moving platform. From a military context, this is unlikely to be beneficial or unlikely to be feasible, given the size and cost of such devices. But when we specifically look at AEDs, so this study by De Vries et al. From 2006 looked at a variety of different brands of AEDs on different vessels in different sea states, and showed that on mannequins, AEDs appear to be feasible and safe in that all the AEDs got wet, and none of the AEDs incorrectly diagnosed a rhythm. But moving on to the only study I could identify looking at human data from real casualties seen by the Royal Dutch Lifeboat Institute. They had 12 casualties, of which 3 received an AED shock. But interestingly to me, one of those shocks was diagnosed incorrectly, in that the AED thought that it gave a shock to a patient who wasn't asystole. Now, this is unlikely to have a material impact on the overall outcome for this patient, but it's still a sign that perhaps AEDs in a maritime environment are not as reliable as the mannequin study might suggest. So how do we apply this to a drowning population? 80% of deaths in divers are due to drowning, so it's still very very topical, but the population, particularly of occupational divers, is quite different in that they tend to be of a younger age, so mostly between the ages of 20 to 40, with high levels of physical fitness. In the UK, all occupational divers have to undergo an annual occupational dive medical, which will include spirometry, fitness testing, blood pressure monitoring, and a face-to-face examination with a diving medicine doctor. And as well as cardiac screening, which will include ECGs on joining and then regularly from the age of 30, with any abnormalities in the ECGs normally triggering investigations like an echocardiogram, Holter monitoring, and cardiac stress testing. All of this meaning that we'd expect our cohort of divers to have a much lower incidence of underlying cardiac disease. Therefore, we'd expect in a drowning casualty, we'd expect shockable rhythms to be less frequent than in an undifferentiated population, perhaps towards the 2% of drowning casualties rather than the 14% that we mentioned earlier. So moving on to the specific maritime environment that we work in, dive sites are very varied. Land-based dive sites can be quite remote, in which case, if you're considering prolonged response times from emergency medical services, having an AED is probably quite sensible. But specifically looking at maritime platforms that I've been using in the past, they can be quite large like this. This is actually an Army landing boat, which we're using as a dive platform. You can see lots of space, very stable platform, could easily perform CPR and attach an AED. But actually, getting the patient to land will be quite slow because this vessel cannot move very quickly and won't start to move very quickly. Furthermore, platforms like this, where you have a large floating raft, essentially, maneuvered by a tug, again, very stable platform, but very slow moving. The faster vessels we use, which are sort of analogous to a lot of the vessels used by sea search and rescue, maritime search and rescue organizations, are fast moving, but with limited space, particularly once you include diving equipment in there. And plenty of our diving will be based off small ribs like this one with outboard motors, where you can see there is just enough room for a casualty on a stretcher, but this is a bit of a sort of false picture in that there is no diving equipment there. The patient will probably have to lie on top of all the diving equipment. And if you imagine trying to perform CPR on this patient while also delivering oxygen and ventilations, and then add in the complexity of attaching an AED and being able to safely deliver a shock where you're getting your other team members away and removing the oxygen, is almost nigh on impossible. So what sort of risks are we going to face using AED in this environment? From the AED itself, the main concern, or one of the main concerns, is exposure to water. Now, the mannequin study I talked about earlier said all of their AEDs got wet, but I'm sure most of the people listening will know from exposure to maritime environments, there's a difference between wet and wet. We don't know, the study doesn't qualify how wet these AEDs are getting. For example, would it be safe to deliver a shock to a patient who's lying in a puddle of water? And can the team make sure that they have the towels and things necessary to dry off the chest? We've spoken about the difficulty delivering shocks in confined spaces. And furthermore, applying an AED will involve interruptions to CPR, both potentially while applying the AED itself, but also while performing rhythm checks. AEDs take around 15 seconds, or can take around 15 seconds, depending on the model, to perform a rhythm check. And we know, well, Resus Council guidelines would suggest any delay of interruption of CPR over 5 seconds should be avoided. Because of animal studies, animal models showing that delays longer than that are associated with worse myocardial damage. So I would argue that applying an AED shouldn't be considered a risk-free intervention, given that if you're committing to do a rhythm check every 2 minutes, where you're interrupting CPR for every 2 minutes, you need to consider what is the actual likelihood of the patient being in a shockable rhythm in the first place. And then finally, again, I'll discuss the potential for unintended shocks. This is something that needs further investigation. Again, we're dealing with very, very small sample sizes here, so it's difficult to generalize. But the fact that of the 3 shocks delivered by this one study, one of them was delivered in error, I think is it would be dangerous to ignore that high a failure rate or unintended shock rate. Moving to the human factors with our dive team itself. Now our dive teams tend to be quite small, potentially only four people. So if you've got 1 casualty, 1 person driving the boat, and then you've got two people to deliver CPR and deliver ventilations, and we want to make sure that actually they know they need to prioritize hypoxia management over using an AED, and essentially avoid them becoming task focused on the AED. AEDs are correctly described as a life-saving intervention in a lot of contexts, but in this context, it's much less likely to be life-saving. So we'd want to avoid our divers who won't be medical professionals from thinking that this AED, this machine, is going to save their buddy. And then finally, the potential for delaying casualty evacuation, both by the delay to, stripping the divers' protective equipment off, and then also the fact that, as we've discussed before, the limited space available, so maneuvering around might mean that they have to slow the boat down, or the fact that if you're on a smaller boat with engine and wind noise, you're going to struggle to hear the voice prompts from the AED. So would a diver be tempted to slow the boat down so that they can listen to the AED properly? I would expect so, but I would argue that the priority in this case should be getting the patient in most likely a hypoxic cardiac arrest to enhance medical services over following the prompts for an AED. So what are we going to do about this? The first thing is training. So all of our divers in the military and similarly in occupational divers have to receive enhanced first aid training. We have a specific course for this, the military diver first aid course, but this mostly focuses on recognition and management of decompression illness and barotrauma. We're looking to change this course to focus more on management of drowning casualties and also cover, how they're going to use an AED if they have access to one in this algorithm. And then protocols. As much as possible, we want to sort of make the decisions on when it's suitable to use an AED beforehand, so that the divers aren't having to make it at the time. So deciding what sort of vessels are going to carry an AED, or where would the divers leave the AED at their nearest sort of land rendezvous point, and also the use of check sheets or protocols for them to carry with their medical modules. And to create this protocol, we're looking to set up a subject matter expert working group of military pre-hospital consultants to discuss what we want our divers to do in this unlikely but potential scenario. So in conclusion, AEDs are a potentially life-saving piece of equipment, and I'm in no way trying to deny that, but they are less likely to be used in my world of occupational divers. And I think hopefully I persuaded you that there are potential risks incorporating AEDs into this environment, as well as other sort of similar maritime search and rescue potentially environments where if hypoxic cardiac arrest is more likely than a cardiogenic cardiac arrest. And in order to mitigate these risks, we need to put in place proper training procedures and protocols for our non-medical personnel. And here are some references, and thank you for listening.
Okay, well, thank you very much for inviting me to present a study that we did last summer. This was for the RNLI, and what we were looking at was improving the floating competency of inexperienced water users in open sea and fresh water. So in 2022, there were 226 accidental drowning fatalities in the UK. And so this is excluding those where criminal activity or suicide were involved. And it is thought that approximately half of these had not intended to go into the water, and therefore they were not prepared. So it was thought that cold shock response is possibly responsible for many of these open water immersion deaths. The reduction in breath hold time caused by the inspiratory gasp, the hyperventilation, also the inability to hold a breath means that there's an increased chance of aspirating water and therefore drowning. In addition to this, the cardiovascular responses of tachycardia, increased vasoconstriction, so hypertension, increases the workload of the heart, and therefore there's the increased potential of adverse cardiovascular or cerebrovascular events occurring, which may then lead to drowning. This risk of drowning is increased if an individual tries to swim in the first 90 seconds of immersion. And this is because the cold shock response is at its peak during this time. And the RNLI Float to Live campaign encourages floating until the cold shock response has subsided because of these responses, and because it will help maintain the airway clear during this period when breath holding can't be controlled as easily. The other additional factor is that it maximizes the air that might be trapped in clothing, which then increases the buoyancy and therefore reduces the amount of activity that's required to keep the airway clear. Now, this was based on research done by the University of Portsmouth, conducting pool-based research studies with experienced open water swimmers. And therefore, the aim of this study was to see whether the RNLI Float to Live messaging could also be used with inexperienced water users, and also in more realistic situations of open water. So we hypothesised that the RNLI Float to Live messaging would enable inexperienced water users to float in realistic open water conditions, such as still fresh water in a lake that you can see on the side there, and in seawater. We also hypothesised that floating confidence and competence could be further improved with individual float coaching. So the participants that we managed to recruit were 25 inexperienced water users. They all reported that they could swim 25 metres, but most of them at most just swam occasionally on holiday. We had a mixture of men and women, quite a wide age range from 22 up to 60 years old, and their BMI was representative of the general population. They undertook 4 floats in still fresh water, and then 10 of these individuals then undertook a further 2 floats in seawater. Prior to each float, we gave them standard instructions. We asked them to stay at the surface with a minimal effort that they would need to keep their head above water for a period of 2 minutes. And this next slide shows the freshwater floats that the participants undertook. So we had 4 floats in total. The first 3 we called were standard floats, and those were undertaken after they walked into the water up to depth between their waist and chest, and then they laid back and did their float, and they were wearing swimming costume at the time. The first float they undertook was without any instruction. The second one was after they'd looked at the RNLI video and poster. And then the third one was with float coaching, which was done individually with a swim teacher. The final float that they did was following a simulated fall. So you can see the picture there. They were stepping off from some steps, and they were wearing summer clothing, which was shorts and t-shirt. Now, this simulated fall was to try and mimic the worst case scenario as far as trapping or not trapping air in the clothing. So by doing effectively a pencil drop, that most of the air would actually come out of their clothing. We were very lucky during our data collection last year. It was during the heat wave, and so the water temperature was 22.9 degrees and the air temperature was 26 degrees. The seawater floats were conducted by a further 10 individuals. They'd already undertaken the freshwater floats, and that was because of logistic considerations. So their first standard float was effectively after they'd already seen the RNLI video and poster and received float coaching with the swimming teacher. So they undertook one standard float that you can see there and one simulated fall wearing clothing. And this time they were stepping off a paddleboard instead of some steps. And again, we were lucky with the temperature. The water was 20.9 degrees and the air temperature was 24.6. So the measurements we took, we asked their, before they undertook their float, we asked them how difficult they thought the float was going to be and how confident they were in their ability to float. After the float, we asked them their rating of perceived exertion, and we also assessed their floating competence. And this was done using the Moran scale by looking at videos of their floating, which, depending on the clarity of the water, was from underwater shots as well as overhead shots. We also asked the participants whether their breathing, so the cold shock response, interfered with their ability to float, or whether shivering interfered with their ability to float. And importantly, we also asked them what information they were given or what practice helped them to float. So looking at the freshwater results first then, we found that that combination of practice and instruction increased floating competency, and that increased with each successive float. So the combination of the accumulative information that they'd been given and practice improved their floating competency according to the Moran scale. So 0 is being unable to float, to a score of 10 being able to do a completely motionless float. They also perceived floating was less difficult with the more floats that they conducted, and as a consequence of that, their confidence also improved. It was interesting that participants anticipated that wearing clothing and the simulated fall would make floating more difficult. So compared to their previous floats, they were more anxious about their float wearing clothing and with the fall. So they thought it was going to be more difficult, and they were, as a consequence, they were less confident about their ability to float. However, their floating competency was actually improved. So the instructions that they had been given were equally applicable to a simulated fall and with wearing clothing. Interestingly, over 2/3 reported that breathing affected their ability to float, and 25% reported shivering affected their ability to float. And we should bear in mind that the water was exceptionally warm for the UK in the summer. It was 23 degrees. This effect of breathing did reduce with repeated floats, as we'd expect, because there's a slight habituation of the cold shock response. And it was apparent that there were passive and active floaters, and hopefully this video will play. So this is what we termed a passive floater, and the activities that they are doing are really to stabilize them rather than to maintain their airway clear. And this other video, and this is an example of an active floater where the actions that they are undertaking are to keep their airway clear. And this was very much related to body fat, particularly of the limbs, and that then determined the advice that helped them to float. Looking at the seawater floats then, pre-float, the participants thought that it was going to be more difficult to float in the sea compared to the freshwater float, which they had done previously, and therefore they were less confident. But interestingly, their floating competency, as assessed by the Moran scale, was actually better in the sea compared to the freshwater. And this is probably due to the greater buoyancy provided by the seawater compared to the freshwater. And this was particularly important for the active floaters. And it was interesting that many of the participants didn't realise that they would be more buoyant in the sea compared to freshwater. On the other hand, the passive floaters who had been able to float in the still lake without moving at all, they actually tended to have to do more activity in the seawater just to balance themselves, because the water was a little bit choppier in the sea compared to the lake. So regarding the floating instructions that the participants found useful, all the participants found that being instructed to have their head back, and in particular having their ears submerged so that they knew how far they needed to put their head back, was very important. Being told to relax and breathe normally, so quite a few people initially held their breath, which meant then that they were very tense. Also, not to worry if their legs sank. Many of them perceived that a proper float was conducted with the whole body on the surface and that they shouldn't move at all. And actually just saying that doesn't matter if your legs sink, that's fine. Spreading their arms and legs for stability, particularly when there was a little bit of chop, and also turning their back to the waves if choppy. And so that was applicable to all of the participants. But for the active floaters, an accurate description of sculling really helped them to undertake their float. So therefore, we concluded that the RNLI float advice can be applied by less experienced water users in realistic open water settings. And the ones that we looked at were in a lake and a harbour in the summer. And it was also following simulated fall wearing summer clothing. Additional content, however, could be included to make the messaging more effective. And this has now been incorporated into the new Float to Live messaging, so that you can see the poster there. It now says, rather than lie back, it says tilt your head back so that your ears are submerged. And it also includes about relaxing and moving the hands as a sort of an analogy to sculling. What's also important is the image that they're showing, is they're showing somebody who's floating in a more vertical position rather than sort of moving away from the starfish shape. One of the limitations of this study was that we had to give the information incrementally. So as well as getting more information with each float, the participants were also getting practice. And so we've conducted further research comparing the effectiveness of float practice and coaching on floating confidence and competence. And that will be presented at the World Congress on Drowning Prevention in Perth. So I'd like to thank quite a few people, particularly the participants, many of whom went considerably outside their comfort zone to undertake these floats. Our swim teachers, the locations where we did the floats, Andark Diving Lake, Andrew Simpson Centre and the Cardiff International Whitewater Centre, and particularly to the RNLI who provided funding for this study. Thank you very much.
Okay. So thank you for having me. It is really a pleasure to be here with you and have the opportunity to share some of my work on physical literacy, and particularly on the introduction of this concept on the drowning prevention and aquatic education. This is a work I'm developing together with my supervisors and colleagues of the Faculty of Human Kinetics since 2022. As I said, this presentation will mainly be centered on physical literacy concept and its added value to the field of aquatic education and drowning prevention. Then at the end of the presentation, I hope I'll be able to share briefly some viewpoints, methodology, decisions behind my PhD project on this. So this work actually started with some professional concerns, as I am a lifeguard and swimming and surfing coach. So This was really what this type of concerns and questions was what motivated me to apply for a PhD project. Also crossing these concerns, for example, why people drown. This is all about knowing how to swim or not to swim. There is something more. It seems that we know already that there's something more there regarding drowning prevention and aquatic education. It's not a matter of knowing how to swim. So I tried to cross the problems and the questions that I had in my work with the literature that I have reading for 10 years. So at the time, I was having difficulties in finding a theoretical framework that robustly would help me to answer some of these questions and concerns. Then I just came across the publications of Professor Margaret Whitehead and mainly Professor Dean Dudley on physical literacy. And suddenly there was some light in my head. Particularly Professor Dean Dudley, being a lifeguard as well and the surfer himself, have made interesting reflections on the role of physical literacy in drowning prevention and aquatic education as well. So these are some of the questions that I have, like how can we more effectively encourage physical activity behavior in blue spaces, like natural aquatic spaces? How can we prevent drowning while at the same time promoting engagement in aquatic physical activity? Can physical literacy help us to find this answer? How can physical literacy concept and its respective philosophical tenets can support research, policy, and interventions for drowning prevention and aquatic education? What does it mean to see physical literacy as a vaccine against drowning? This is a really good metaphor from Professor Dean Dudley. How do we characterize physical literacy development when we talk about the aquatic environments and our interaction with it? How can we assess physical literacy, aquatic physical literacy, while assuring the use of valid, reliable, and authentic methods, and so on? So as you see, there's a lot of questions. It's basically a whole career around that. Let's see what's happened. So this is the team that is working with me, and as you see, it's an interdisciplinary team, an intersectorial partnership, I would say. And this, for me, was the ideal partnership, because I have this notion that is really important for us to start working with people of another sectors to support a more holistic view of aquatic education, blue physical activity promotion, and drowning prevention as well. So what's physical literacy really? Despite the origin of the concept of physical literacy can be tracked to the 19th century, it was only in the beginning of the 21st century that we witness its fast dissemination among practitioners and academics, supported by the discussions and the great work developed by Professor Margaret Whitehead. This work was developed between 1993 and 2001, and offer for the first time a robust theoretical and philosophical support to the definition of this concept. So what can we understand by physical literacy really? Professor Whitehead refers to it as the motivation, the confidence, the physical competence, knowledge, and understanding to value and take responsibility for engaging in physical activities for life. Associated to the definition, there's a set of physical literacy attributes that support it and may characterize a person in their physical literacy journey. So physical literacy, it's not a product, a state. It's more of a journey that a person pursue through their whole life, since birth to the death. Philosophically, there's some guiding principle that we should consider, because there's important implications for policymaking, research, and pedagogical practices. So the three principles associated to physical literacy have been the monism principle, that tell us that there's really different dimensions of human condition and development, but we never should analyze these dimensions just by themselves, separately from each other. Then we have existentialism that says to us that interactions with the environment really form the individuals and their journeys. So the second basis in this notion is that humans create themselves as they interact with the world. So it said to us there is an individual view that people have towards the world and their environment that is really important to consider. A third aspect is phenomenology, that basically it's a view that every learner experience in the world from a unique perspective, as every learner has his or her own unique set of experience and affordances. As you see, there are some studies, most conceptual studies developed on physical literacy. Nowadays, the research is really focused on building instruments that stay committed to these principles, these philosophical principles. Nevertheless, naturally, other reinterpretations of the concept were developed by countries as Australia, Canada, New Zealand, that basically appeared because there was a need to address cultural meaningfulness to this concept. So despite this, there's basilar tenets that remain, and the framework and the definition created by the consortium of Australian researchers, for example, it's of particular interest for us in Portugal, since it is perfectly aligned with the principles and methodological guidelines of our physical education curriculum. An example of common tenets between definitions are that physical literacy is for life, okay? It's for everyone. It's an inclusive concept. You can develop your physical literacy despite your context on your individual condition. Every person can develop it, so it's related with inclusion. You also can develop your physical literacy by interacting with different environments, and this is a key aspect of the different definitions. This is an illustration of the different components of physical literacy. As I said earlier, we always should see it as a whole, okay? It's basically, despite this simplification that allows us to understand better the concept, it's always important to look at it having in mind the philosophical and theoretical principles. So by addressing the Australian framework, we can describe physical literacy development as an interdependent development and mutual influence of 4 domains of learning or human development, as you know. For example, the physical domain, it means that the skills, the fitness a person acquires and applies through movement. It implies developing elements like movement skills, moving while using objects like a board or a vessel, object manipulation like a ball or other objects, the development of skill-related fitness, health-related fitness as well. As for the psychological domain, it means that It addresses the attitudes and the emotions a person has towards movement and the impact they have on their confidence and motivation to move. It implies elements like engagement and enjoyment, confidence, motivation, connection, the sense of connection to place, and self-regulation in terms of emotion and physical self-regulation. The cognitive domain, it says us there is it means that it is a person understanding of how, why, and when they should move. Okay, and the elements that we can see here, it's about the content or context knowledge that is important, really important for aquatic education and drowning prevention. The knowledge about safety and risk management, the rules, the knowledge about rules, the strategies and the plannings or tactics that a person can afford. At last, the social domain, there is a domain that was headed by the Australian group. It says us about a person's interaction with others in relation to movement. It speaks about relationships that we have in the context of physical activity, collaboration, ethics, and society and cultural aspects. This is a dimension that usually we don't see as much, we are not seeing as much in aquatic education and drowning prevention, and our thesis, this is made key for future interventions as well. Of course, the individual factors didn't exist without the influence of environmental, social, and cultural ones. So we have always to address it and have a more ecological view also regarding drowning prevention and aquatic education. I'm leaving with you with this model. This is a really important model that basically helps us to understand the relationship between physical literacy development and the health development. Okay, here with, as you see, with the physical activity behavior as a mediator of both. If at one way you may develop your physical literacy, this will help you to have more physical activity behaviors and increase the quality of your physical activity behaviors, and through the physiological, social, and psychological adaptations, we may see physical health, mental health, and social health modifications. And the same happens in the other way. Okay, as your health improves, you are capable of maintaining your physical activity behaviors and the quality of it, and this will help you to develop your physical literacy. One aspect that we are trying to develop in the PhD project is the inclusion of integration of ecological and physical literacy models. We know that ecological models have been applied, for example, for Professor Salis, for physical activity promotion and injury prevention. Now, our thesis is that for interventions, it will be important as well for drowning prevention and aquatic education to start to have a more ecological view of its development. And this is an illustrated example of our proposal. So another topic that I would like to present you.
Dora, it's a fascinating subject, and I'm getting slightly engrossed. Unfortunately, because of our time constraints, I was wondering, would you be happy to just bring us to a summary close on your presentation there?
For sure. Sorry, I got lost in the time.
Worries. It's great stuff. Thank you, Dora.
So I'm sorry because I'm not the English native, so for me it's a bit more difficult. I would show you some thoughts about the conceptual part of aquatic competence. Aquatic competence is being applied for drowning prevention since 2013 mainly. Our thesis is that possibly, as the research is evolving and the knowledge is evolving, aquatic physical literacy would be an appropriate concept to present now. Okay, starting from the knowledge that we assess already, and we'll define it like this. Okay, aquatic physical literacy would be a set of physical competences in blue spaces, attitudes, values, knowledge, understanding, and as well social behaviors. This is the new aspect, to value and take responsibility for engagement and water safety behaviors, and in water safety behaviors and blue physical activities for life. Our thesis is that physical literacy can constitute a common ground to support the establishment of collaborative initiatives between research fields, professionals, policymakers from interrelated areas such as aquatic education, safety, environmental sustainability, physical education, sports, public health, and so on. So, but there's a discussion to start that I will propose to you. Because an additional point is that while being supported by robust scientific rationales or models like ecological dynamics or ecological models for health behavior, this aquatic physical literacy perspective may add some interesting thoughts on our research and our interventions. So possibly we think it will address part of the theoretical deficit that we are seeing in the aquatic education and drowning prevention empirical literature, and may support our work in the future.
Yeah, okay, thank you. Okay, what I've been involved with is clinical study of safely applying prolonged breath holds of greater than 5 minutes for radiotherapy in patients. And this is a study where we've raised over 0.8 million euros, and I've just currently finished a Marie Skłodowska-Curie Fellowship supported by the European Commission in Amsterdam, and I'm part of a large Dutch project grant from the KWF. Now, in our experiments, patient safety is paramount. And what I really want to present to you today is a spin-off of something we've been finding in this research. So, to introduce the problem, for unexpected drowning during recreational swimming in otherwise healthy humans, there's no accepted explanation for this and no accepted solution. There's also enormous television publicity for unsubstantiated feats of long underwater breath holds. And there's promotion of the dangerous myth about the ability of humans to breath hold underwater. This myth originated by the great Schollander himself in 1962, and the myth is the almost universal misunderstanding that humans possess remnants of the diving response of diving mammals, which was Schollander's great work in the 1940s. And humans don't possess this ability. And if I just show you the evidence that shows this, here I've taken seal data from Schollander himself and the great study by Zapol in 1979, and our own data on breath holding and some nice face immersion studies by Gualdi in 2009. And the vertical scale here, we have muscle blood flow, cardiac output, and heart rate. First of all, let's look at Weddell seals breathing on the surface. This is Zapol's study. We're being recorded live, so I can't actually or sensibly describe what he actually did, but let's assume this is a seal on the surface and then diving underwater. And you can see the point about seals is that on the surface, they've got a cardiac output of something like 70 mils per kilo per minute. Sorry, a muscle blood flow of 70 mils per kilo per minute, which is the triangle. Cardiac output's about 40 liters per minute, and heart rate's about 50 liters per minute. Now, seals can dive underwater for about 40 minutes. And the Zapol study shows that the key point about seals is when they, first of all, when they dive, they exhale, they obviously breathe air, and their muscle blood flow goes down to 0. And this is the key point about the diving response of mammals. This is the primary response. Now, obviously, if you've got a cardiac output of about 40 liters per minute and you reduce your muscle blood flow to 0, your blood pressure will rise enormously and you'll explode. So to get around that, the secondary response of seals is they reduce heart rate to 15 beats per minute or less, and they reduce cardiac output to about 5 liters per minute. But this is very much the secondary response. And of course, not every heart rate fall signifies a diving response, and this is the whole problem that Scholander got into. Let's now look at humans, typically 70 kilos. If they're breathing room air, their muscle blood flow is about something like 25 mils per kilo per minute. They have a heart rate of about 70 beats per minute, and cardiac output is 5 liters per minute. Now, when humans breath hold, they inhale air and breath hold, muscle blood flow doesn't really change. So I've never seen a very good study measuring muscle blood flow in humans during breath hold, either on the surface or underwater. But heart rate does not change during breath holding, and cardiac output doesn't change either. And even if you look at humans where they breath hold with face immersion in cold water at 7 degrees centigrade, again, inhale air, breath hold, and they held for 3.8 minutes in Guaraldi's study, the heart rate still doesn't fall below 50 beats a minute. And Scholander's misinterpretation is that he's trying to argue that these heart rate changes, which you remember, that's really the secondary response of the seal, it's not the primary response, are the remnants of the diving response. And they aren't. And there's lots of reviews show that if you look at heart rate in humans during breath holding, or even in diving, it really doesn't go below 50 beats a minute. Now, resting humans on land can safely breath hold for over 5 minutes after mechanical hyperventilation and pre-oxygenation with oxygen. And this is data from our study in 2014. And this is a subject doing a safe 9-minute breath hold. And look at instantaneous heart rate. It really doesn't change. It fluctuates, but the baseline heart rate level doesn't change for a 9-minute breath hold. And at the break point, heart rate still hasn't risen. Also, oxygen saturation is still 100% after a nearly 9-minute breath hold in humans breath holding air. And the end tidal CO2 is still, it's a little raised, but it's not particularly abnormal. And for humans, the keys to safe prolonged breath holding are maximum lung inflation, hypocapnia, and in humans, the only way to induce hypocapnia is by hyperventilation, and pre-oxygenation. Now, for humans, the dangers of breath holding are, first of all, breath holding with vigorous exercise, classically swimming underwater. And there's some very good scientific evidence supports this. A lovely study by Andrew Cummin in 2000, 8 subjects during or after a 100-watt exercise on a bicycle ergometer. If they deflate their lungs, they can only breath hold for 15 seconds. Not only that, at break point, some of them, well, they were all alarmingly desaturated. SATs were 73%. 2 had cardiac dysrhythmias and had to be removed from the study. What's also fascinating is this study was actually funded by the Home Office because it has huge implications for physical restraint. And also what is fascinating is it's only ever published as an abstract. And I've never been able to persuade them to produce a full paper on this. Now, the other danger of breath holding for humans is breath holding following voluntary hyperventilation, but in air. And I'm now going to give you a demonstration, or give you some data that shows this quite strikingly. So the methods that we were employing at the time, with ethical approval, this is just from one healthy subject resting, obviously on land, not in water. And we measured breathing from airway pressure, end tidal CO2, heart rate, blood pressure, and pulse oximetry, oxygen saturation. They were mechanically hyperventilated in air to an end tidal CO2 of 20 millimeters of mercury and kept at that hypocapnia level for 5 minutes. Then they were instructed to exhale and breath hold for as long as they could. And what I will show you is that the amount of arterial desaturation you get during a 1.8 minute breath hold. So here we have instantaneous heart rate, which just shows how heart rate doesn't really change during breath holding. Expired PCO2, that just shows you that they weren't breathing, in other words, they're breath holding. This is blood pressure measured from a non-invasive FiniPress, and the gaps there are just when the machine recalibrates. And this is pulse oximetry, arterial oxygen saturation. And you can see that it falls. And at 1.8 minutes, we had to tell the subject to break the breath hold. The subject was not aware that they were desaturating. The subject had no chemical drive to breathe and no desire to breathe. What's even more scary is the oxygen actually, the saturation continued to fall after they restarted breathing. And it reached 83% in this case. So the subject had to be told to restart breathing. And in fact, we were so shocked by this result, we immediately changed all our safety protocols, and we've never seen this again because we've changed the protocol to make sure it doesn't happen. But this shows you the obvious danger for humans breath holding underwater, having previously hyperventilated. They develop severe hypoxia in hypocapnia. This could cause unconsciousness, and of course, failure to resurface and to restart breathing, and ultimately cardiac arrest. So the conclusions, a very simple explanation for drowning. This is during recreation swimming in swimming pools, entirely innocent and unexpected. Healthy swimmers voluntarily hyperventilate excessively in air to attempt to swim long distances, in other words, for long durations underwater. And of course, we've all done it, and we've all competed with our mates to see who can swim furthest underwater, and you hyperventilate first. And the trouble with hyperventilating in air is and exercising underwater is this rapidly induces hypoxia. The hypoxia could cause unconsciousness underwater, failure to resurface and restart breathing, and ultimately cardiac arrest. And the steps to prevent this, it's very simple. Widespread publicity and promotion of the advice given by the American Navy physician for their diving teams, Butler, in 2004, nobody should breath hold underwater for more than 1 minute. Thank you very much.
Thank to the Physiological Society and IDRA for having me, for the opportunity to share part of this important resuscitation drowning paper that I did with my colleagues Piscini, Eller, and Dunn. As we know, drowning is defined as the process of experiencing respiratory impairment from submersion or immersion in a liquid. Like other injuries, drowning could be classified into two major groups as fatal and non-fatal drowning, and the latter could be with or without morbidity. To highlight on drowning, the respiratory and cardiorespiratory arrest have a unique presentation that has different pathophysiology than one due in the primary cardiac cause. Universal CPR protocol for pre-hospital resuscitation were developed with a focus on CPR due to cardiac etiology. As a result, adaptations are required to best support on drowning person. Basic and advanced support protocols for drowning are based first and foremost proper airway management to correct or reverse the hypoxia and increase the patient likelihood of survival. So that's why we need specific protocols for drowning resuscitation, and we have our evidence-based and best practice protocols. Emphasizing prevention is paramount. That was highlighted by several authorities on the matter. For instance, the American Heart Association emphasized this in their pediatric chain of survival in '92, and in 2014, Spielman and colleagues published the drowning chain of survival, where the principal emphasis is on prevention, considering drowning as an avoidable injury. Regarding on drowning resuscitation consideration, talking about the patient position, once in the dry area, the casualty should be placed supine on a flat horizontal surface. The Trendelenburg position increased fivefold the chance of regurgitation and increased mortality by up to almost 20%. Conversely, the reverse Trendelenburg position is associated with the increase of cerebral hypoxia and hypertension, and consequently ischemic brain injury. On the other hand, the horizontal position is associated with better cerebral perfusion during resuscitation and should be therefore be adapted. Furthermore, attempts to drain water from the lung or stomach have the potential causing significant injury and unwanted regurgitation with subsequent aspiration and increased hypoxia. At the same time, it's not advised to perform any routine airway clearance maneuver prior to start of resuscitation and placing the casualty in lateral decubitus to inspect or clear the airway. This will also delay the initiation of ventilation and CPR if needed. Frequently, gasping is seen in unconscious drowned patients. This is not normal or effective breathing, as we know, so should be considered equivalent and no breathing. If the person is not breathing or not breathing normally, that's gasping, 5 initial breaths should be delivered. I'm talking about ventilation in drowning resuscitation. There may still be remnant liquid in the upper airway, as well as increased pulmonary resistance. As a result, the first ventilation of subsequent may not be effective in drowning patients, which limits our ability to get oxygen, to provide oxygen to the brain and lungs. As mentioned, rapid initiation of this ventilation is critical to reverse the hypoxia. If no signs of circulation of pulse are found or in depth, chest compression should be started doing CPR. Hypoxemia is a common finding among drowned patients, right? A recent scope review was conducted examining oxygen administration and ventilation strategy in drowning. The review concluded that the service able to provide inspired oxygen, it is reasonable to include it as part of a bundle of care for drowning patients until arterial oxygen saturation can be measured accurately. The optimal strategy to ventilate a patient in respiratory or cardiorespiratory arrest was also reviewed, but little data is specific to drowning was identified, and the review recommend following the recommendation for airway management of the ILCOR Advanced Life Support Task Force that suggests the using of BBM for all cardiac arrest by trained responder until an advanced airway can be placed. Referring to asynchronous ventilation, some studies have suggest that responder can perform CPR without interrupting compression by delivering asynchronous ventilation. This could in turn have an impact on patient survival following non-drowning cardiac arrest, according to animal model study. On the other hand, in animals for hypoxia-induced cardiorespiratory arrest, there are better results in conventional CPR by stopping compression to deliver ventilation. Once an advanced airway is in place, asynchronous ventilation every 6 seconds with continuous compression can be performed. When we talk about drowning resuscitation, compression only is not the technique of choice, definitely. CPR that include ventilation was associated with higher survival to hospital admission and overall survival compared with bystander CPR that delivered chest compression only, including all causes. Furthermore, recent scope and review identified 2 studies that demonstrate significant improvement in outcomes following drowning with the incorporation of ventilations. Talking about manual or defibrillation with an AED, BF and pulses BTAG are the arrhythmias responsible for most of sudden cardiac arrest. BF could occur in the early stages of a cardiac arrest because drowning, although the reported incident of a documented shock rhythm in drowning patient is between 2 and 14%. In drowning cases, progressive hypoxia results in bradycardia, pulseless electrical activity, and finally asystole, all non-shockable rhythms. The mentioned scope of review for ILCOR on drowning resuscitation recommends that the high quality of CPR be the emphasis for drowning patient and not be delayed obtaining an AED or a defibrillator. Regarding the complication during resuscitation, the most common complication during resuscitation is a vomiting or regurgitation. According to this study that we use as a reference, 65% giving only ventilation when are in only separate the respiratory arrest, and 86 when given CPR because are in cardiorespiratory arrest. This is therefore a common complication in drowning cases producing emesis aspiration. Regurgitation should not be taken as a sign of patient improvement, of course, so do not stop on these cases other than roll and clear the airway. Moreover, unique to drowning, the presence of foam in mouth and nose and the drowning person is common due to a non-cardiogenic pulmonary edema, so it should not be considered as a regurgitation. This foam can be removed quickly and come up again and again. Therefore, ventilation, ventilation should be continuing or even ventilate over the foam and try to clear it only in interval during compression by the way airway suction would be necessary for these cases of foam. So summing up, when the prevention fails, resuscitation practice are critical in order to improve survival and reducing sequelae in drowned person. Considering hypoxia as the main cause of respiratory arrest and cardiopulmonary arrest in drowning patients, protocols for pre-hospital resuscitation should be different from the universal CPR algorithm. On the contrary of sudden cardiac death, hypoxia, cardiorespiratory arrest, drowning can often be reversed with early airway management and ventilation. The resuscitation of a drowning patient involves a series of specific actions that include the emphasis on early airway management and ventilation and the attention of those other complications that we were talking about. Quality resuscitation of drowning person is a team effort that involves lay person, rescue, and EMS personnel, improving teamwork and communication among this group may be one of the most effective measures to improve survival. Anyway, prevention continues to be the most important and cost-effective public health strategy. Thanks, Paddy, and everyone. Here in my ResearchGate profile, soon you can have the presentation of the or the paper, or the entire paper, the whole paper.
Okay, thank you. So I'm from Finland and I work for Safety Investigation Authority of Finland here in Helsinki. We have not done any scientific studies, but I would like to tell you about our team study on drownings that we did in our organization and how we do this kind of things in Finland. Here you can see a couple of photos from 2021 in real places where people have drowned. We have a lot of this kind of information that we have used in our investigation. But I will start with a couple of words about Finland. We are, maybe, I don't know how much you know about Finland. We are a Nordic country with 5.5 million inhabitants. So Finland is quite small country in that way. But we have quite large land area. It may be surprise for you. It's about the length of Finland is around 1,000 miles, as you can see in the map. And what's special related to drownings in Finland is that we have a huge amount of lakes. It is said that Finland is a country of 1,000 lakes, but it's not 1,000 lakes. It's almost 200,000 lakes. But I must say that it's depending on the definition, how small amount of water is considered as a lake. But anyway, we have a lot of lakes which you can see in the map. The map is made for environment purposes, so it says what is the quality of water in different parts of Finland. So never mind about the colors there. But anyway, you can see a lot of water. More than 600 rivers, many of them are quite small, but anyway, a lot of lakes and rivers. And we also have Baltic Sea coastline, which you can see in yellow color in the southwestern part of Finland. We have a lot of summer cottages. It's related to drownings, you will see it. And every summer cottage in Finland has a sauna, I would say that. And the climate here is that lakes are frozen in wintertime. maybe from November to April, May, depending on how north you are. But they are frozen. You can walk or ski or skate or something like that on the lakes. And in summertime it is quite warm here, but summer is short. It's from June to August. And in Safety Investigation Authority, we say that we are multimodal. For example, in UK, I know that you have organization for railway accidents, aviation accidents, maritime accidents, separate organizations. But in Finland, because we are a small country, we do many things more together. So we are multimodal, and we investigate all those accidents in the same organization. And I am the chief safety investigator in the other accidents. You can see right hand side, the lower drawing. It's my part there. And why we do the investigation is only to promote general safety. We don't find out who is guilty or something like that, only to improve safety, just like NTSB is doing in US and our sister organizations in many countries. So normally we investigate single serious accidents, which you can see here a couple of photos about them. That's our main work. But we can also do theme studies. We have done several of them, and 2021 we did one. It was about drownings. Sorry, I take my watch there. Yeah, I can see the time. So in 2021 we started a drowning theme study, which we had done already 10 years before once, but now we did it better way. We learned from the previous one, and we did a lot of work to do this properly. And what we did, we made an agreement with our emergency response center, which is covers whole Finland. Made an agreement that they will notify us whenever someone is found in the water, and usually dead in water. And it worked quite well. We got the phone call immediately, day or night, 24/7. And then we took the case. We contacted the local police, emergency medical services, rescue services, and other authorities on the site. We didn't go there. It would be too difficult to go immediately to the site. When you can see the number there, total number of drownings was 165. So the year was quite busy for us. So it was enough that we contacted the authorities and got a lot of information about those cases. We had an investigation team which consisted of 10 experts that who had worked for us before. They were really experienced and good team. We also, of course, not immediately, but later we got the autopsy reports. Actually, we didn't take the reports, but we talked with pathologist and discussed about every case, what was the point there. We got the information from autopsy, and it was very helpful. And so total number of cases was 165. Here you can see an example what kind of simple results we could get. 82% were male and rest female. And that number is only accidental drownings. There are every year quite amount of suicides in Finland, unfortunately. And sometimes it happens that someone dies natural way when they are in water or in boat or something like that. If it was clear that the case was suicide or natural death, I mean disease, then the case was excluded. We took only cases where the person would have survived if he or she had been on ground, not on water. So I will show you a couple of examples what kind of information we received from with this investigation. In every case we tried to find out what was the person doing when he or she was drowned. And here you can see the numbers. Biggest number is swimming and splashing around or cooling down in the water. There are splashing around and cooling is there because in most cases it was really near it was not far away from the coast. It was really near in a water just before in front of summer cottage or something like that. There was hardly any cases in which the person was swimming long distance. And there are other groups which we could identify falling into the water and traveling with watercraft and falling through ice and that kind of things. This was important to get these numbers. How we can classify them. Some more examples what kind of information we got, because autopsy was done for everyone except maybe one only, and also we got the alcohol samples from blood. So we knew that 44% was under influence of mostly alcohol. We found out that half of the people was more than 67 years old, and mostly they happened inland water. 13% only in sea, mostly in lakes and some of them in rivers. Here we found out that there are peaks in summertime. Those that indicates how the drownings, how often they occur in winter time, spring, autumn, and there you can see summer is the worst time here in Finland. Here you can see more detailed the age groups in which the drownings took place. You can see the most of them are more than 50 years old. Children, only a couple of children, fortunately. But we should have our targets that it would be 0, and we are quite near that we could achieve that. And in lower picture you can see that for example that falling through the ice happened only for males. Also males are drowning with watercrafts, not at all female persons there. These are just examples what kind of information we quite easily got from our investigation. We also know now how the cases are located in our country. You can find there a couple of small, large cities in southern part of Finland. There's Helsinki, our capital city, That number is 17 there, and then there are a couple of other cities, and then the countryside locations where people have a lot of summer cottages, but they are all over Finland. Lapland, northern part of Finland, is really rural area. Their numbers are smaller because of that, I think. We also got a lot of photos from authorities, and here you can see what kind of boats were involved in the accidents. Very old ones, very bad ones, not safe ones. And maybe this one is a little bit exotic for you, because we have those icy conditions. 25 persons fell through the ice on foot. They were on foot, on a snowmobile, kick sled. Some of them were fishing, and just an example how we presented our results. We also published 165 stories. Unfortunately, all of those are not in English, but here you can see one quite typical one, very sad story. We have, like I said, 165 sad stories published during our investigation. I published them, all of them, in Twitter, and they were very popular here in Finland. And I'm finishing soon. One finding which was kind of new for us was that more than half of all the persons who drowned that year had a cardiac disease. 56% had cardiac disease, and 67% of them, it was undiagnosed. So person didn't know that he or she had trouble with his or her heart. That one might be a finding that should be investigated more or made some research. Our final product was an investigation report, which is 66 pages. It includes a lot of text, photos, illustrations, graphs, and those stories, and also recommendations for organizations in Finland. The report is available in Finnish, Swedish, and also English. Please, if you are interested, you can check. Link is there, and you can Google it also. And if you would like to follow what we are doing right now and in the future, you can follow us in X, in former Twitter. Kiitos means thank you in Finnish, and tack is thank you in Swedish. Two of our national languages.
Well, thank you very much for inviting me back again. So this presentation is based on the MSc project that Adam Wilson did with us, and he was looking at the evaluation of online information on the cold shock response to accidental immersion in cold water. So the initial responses to cold water immersion are collectively known as the cold shock response, and these may be responsible for many of the annual open water deaths that occur in the UK. As I've sort of said in the previous presentation, the cold shock response comprises of an inspiratory gasp, hyperventilation, and inspiratory shift, all of which decrease the ability to hold your breath, and therefore increase your chances of water aspiration and therefore drowning. The cardiovascular responses, which are an increase in heart rate, hypertension, and therefore increased cardiac output, which put an increased workload of the heart, may also cause cardiovascular incidents, and increased number of arrhythmias may also occur. And this is particularly interesting following the previous talk, where many of the drowning victims actually had an underlying cardiovascular disease. So this extra workload of the heart during the initial immersion may precipitate drowning. So public awareness of the risks associated with colder water immersion, so the respiratory response as well as the cardiovascular responses, and the potential mitigations that one might undertake are really important to prevent drowning. Now, the internet is used by about 95% of the UK population, and it is the primary source of information for many of the things that we're looking at. However, previous research has indicated that websites which are looking at health information were found to be of poor quality, inaccurate, and outdated. So the aim of this study was to analyse the publicly available internet information on cold water immersion and the cold shock response for accuracy and quality compared to the gold standard published peer-reviewed research. So we hypothesised, based on previous studies on health information, that the information on the internet pertaining to cold water immersion and the cold shock response would be of low accuracy and quality compared to the peer-reviewed scientific literature and be too difficult for most readers to comprehend. So the methods we undertook then, we used a search protocol described by Jetha et al. 2011, and we used a Google search engine, and this was conducted in April 2021 and looked into search terms on unexpected cold water immersion and the cold shock response. And on the right-hand side there, you can see all the search terms that we input into Google. We looked up the first 4 pages of links for each search term. So that returns approximately 40 web pages for each of these search terms. Web pages were excluded if they were not written in English. They were from peer-reviewed academic journals. They were behind a paywall and therefore not accessible unless you paid. They had expired and therefore were not fully accessible, or they were just news articles of a historical event, or if they just contained links. And they were also excluded if they did not mention unexpected cold water immersion or the cold shock response. So once we'd got all of these websites, they were then evaluated based on their technical quality, and this was done using the JAMA benchmark, which was described by Silberg et al. 1997. And this looks at things like, has the website got information on the author, what the date that it was last updated, whether it's been endorsed by a professional body, and sort of general technical information like that. We looked at readability using the Fleisch-Kincaid grade level as well as the Fleisch Reading Ease score. And the accuracy was compared to peer-reviewed scientific publications, which I'll show on the next slide here. So this diagram is based on the review done by Mike Tipton in 1989 and has additional information added from subsequent papers that you can see down the side. So from this, we then took certain terms that we thought would then explain the cold shock response. So we were looking for the responses, the respiratory and cardiovascular responses, to be included in the website. We were looking to see that it also contained information about the dangers associated with cold water immersion and the cold shock response, as well as factors affecting the cold shock response, so mitigations and different conditions that might then affect the responses we see. So looking at the search then, following putting those 14 search terms into Google, we came up with 508 web pages. Duplicates were then excluded, as were non-relevant web pages. So that left us with 72 web pages which were included for assessment. Further 6 web pages were identified from links within the original web pages. And that ended up with a total of 78 web pages from 67 different websites which were identified. So looking at the web pages that we identified, 73% were created or updated between 2016 and 2021. Most of these were from the UK or from the USA, and the information was very easily accessible. So the information was accessed within 1.2 clicks. The quality, the technical quality, however, was rather poor, with a JAMA score being on average 1.3, the maximum score being 5, with a score of 4 being considered to be of good quality, and that was only achieved by 3 web pages. On the other hand, the readability was good using both of the scales that we used. The readability was between about 12 and 15 years old, and so that is considered a good level of readability. Looking then at the accuracy of the websites, this diagram shows the percentage of websites that include in a particular term. And this first section here is the responses, then we've got the dangers, and then the other factors involved. And we found that the average website contained 10 out of our total 19 categories there, and looking at the responses, most web pages included something about the respiratory response, and the gasp reflex was the most commonly reported. Fewer websites reported the cardiovascular responses to cold water immersion, and those that did, the most commonly reported was hypertension. Most websites reported that cold water immersion was dangerous and that drowning was the main danger. All of the websites identified that water temperature was a factor in the cold shock response, but there was few actually that mentioned any other water conditions, such as rips, tides, or inclines or anything like that. I should have mentioned actually that we accepted lay terms, so for instance, hyperventilation, we'd accept an increase in breathing, but not a change in breathing. So we were expecting to have the right direction of change. We identified that about 20 websites gave inaccurate information and 19 gave potentially inaccurate or potentially dangerously inaccurate information. The most common one being that the cold shock response only occurs in water below 15 degrees. Now, this could be dangerous because somebody might think that, well, if the water temperature is over 15 degrees, I'm not in danger. And if you remember in the previous presentation, if you listen to that, about 2/3 of our participants who were in water at 23 degrees found that their ability to float was affected by the cold shock response. And from data in our laboratory, this is an individual who was immersed in water at 27 degrees. And we can see that they had a large cold shock response. Their breathing frequency, which is shown in the black line, and their ventilation was increased on immersion, head-out immersion, and that was maintained for at least a minute. So the cold shock response is maximal between 15 and 10 degrees, and there is individual variation on how sensitive somebody is going to be. But I think it would be dangerous for individuals to think that above 15 degrees, there's no danger of the cold shock response. Other potentially dangerous inaccurate statements included the cold shock response only occurs in water below 15 degrees Fahrenheit, or that it does not occur until after 30 seconds in cold water, when in actual fact the maximum response is within that first 30 seconds. Other errors include cold shock response provides protection, or that only the diving response and bradycardia occur within cold water immersion, but that would only be the case if it was just facial immersion. Other statements that might then invoke people to undertake behavioural responses that may put them in more danger include remove clothing that may be weighing a person down. Now we know that clothing traps air and therefore improves an individual's buoyancy, therefore helping them maintain their airway clear of the water. When in water, when entering water, immediately call for help. Now, if this is done by waving the arm above the water, then this would mean that their head might then go underwater, and therefore they may aspirate water. Another statement was, as the water temperature drops, keep swimming until the person's body is used to the cold. Well, on initial immersion, we would want them to wait until they started swimming. And in many cases, in cold water, if you swim, you're actually going to cool faster than if you stay still. So from the web pages that we examined, the web pages were found to be easily accessible, widely available, and had good readability, but the technical quality was poor. The accuracy was not optimal, with incomplete or poor information provided in some of the websites. Most web pages included information on at least one respiratory response. And this is good because for most individuals, it's possibly going to be the respiratory response that would mean that they would aspirate water and cause drowning. So information about that is very important. However, the coverage of the cardiovascular component of the cold shock response was sparse, and this then may lead people to be unaware of the potential difficulties that may arise with people with underlying cardiovascular disease. The practical mitigations tended to be vague, and if this is going to be recalled in an emergency situation, they should be very clear and easily followed. And as I've already said, inaccurate statements were included. The limitation, obviously, with this website, of this research, was that the website search was conducted in April 2021, and so things obviously change very rapidly on the internet. The search method aimed to replicate the general consumer's way of searching, but everybody searches individually, and so therefore they may have come up with different web pages to us. Therefore, we conclude that web pages should include more information on the physiological responses and dangers of accidental immersion in cold water, as well as clear, practical strategies to mitigate the cold shock response and therefore prevent drowning. Thank you for listening.
Thank you. Is that all good for you now? Are you hearing me well as well?
It's perfect.
Fantastic. Well, thanks so much for having me. I'm here representing SOS Mediterranee, and also my colleague Mark, who can't make it today, was a kind of a key part of what we're going to look into. But we're going to look into, responding to mass casualty events in the central Mediterranean. It's not really an academic approach. It's more of an experiential one, because I think it's still a fledgling field of rescue, but hopefully interesting, as your work has been to me throughout this session. Just briefly, who we are. This is one of the two vessels we've operated, and we have 4 working ribs. It's kind of like a FRC style setup. Operating off here, we can take about 412 people within SOLAS regulations currently, and unfortunately on our old ship have taken up to 1,000, rescued about 37,000 people since 2016. Obviously, this is nestled within a kind of political debate that I'm not going to touch on, and I'm really not the right person to. I'm an operational person. I'm search and rescue manager, and have led the SAR team in recovering people from boats in distress to these motherships for a couple of years. So that's my background. It's quite an unpleasant video, but I think it gives you the context of what we're working through. And then I'll go on to, provide you with a description, but feel free to look away, because sometimes it's not helpful to watch this kind of stuff. Over to you. Yeah, and I'm not sure what the audio is like here.
I need the bow to listen up to try watch out. Pull back from the boat. Right there. You're in charge of it.
Yeah, so I think that gives you the kind of situational awareness of what we're managing here. Obviously, like this PowerPoint follows our journey through trying to learn how to deal with this situation. And we started really with unknown risks. It was very hard for us to even figure out what was killing people out here. It was really hard to see what was going wrong. And in terms of techniques, training, and equipment, there was most rescue services that I was aware of, while forming a valuable underpinning to our work, weren't set up specifically to manage, say, 80 people in the water at a very short period of time. You know, we're managing boats here from, 190 people on a boat like the one you see here, up to the biggest one I've been involved with is maybe 725. So potential for a lot of things to go wrong there. And yeah, and if the existing material didn't adequately mitigate those risks. So I'm going to talk you through each of those steps, how we address those problems, and then briefly mention future elements. Again, this is, I promise you, my last unpleasant video, but I think it demonstrates the status quo of rescue. This is one of our first rescues managed by a captain on scene. And again, you see what would be appropriate in a normal event. It really isn't in this context. We've gotten much better. Again, no judgment to him. I'm not jealous at all for being the first one to see what happens when you try a shipwreck. Another thing it shows that I'll talk through is just what goes wrong. So high swell, about 7.5 tons of people on here, with all supported by a thin bit of plywood. And within more than 6 people per square meter, you start having crushing injuries. And basically this, deck's being forced down by 7.5 tons, but also you'll see a great deal of people kind of falling overboard as the boat collapses. And I think here's a kind of visual. This is what happens. The actual reduction in space increases. So a further reduction in space, and you end up with water coming into the boat. A lot of people drowning or falling overboard, and a lot of people drowning inside the boat being crushed. We rescued a bunch of people with bite marks on their legs, and a bunch of people in the bottom of the boat there dead. In addition, fuel tends to rise, so we have fuel mixing with the water, and a lot of people intoxicated with the fumes and extensive fuel burn. So quite an unpleasant place for humans to be. There was also other elements, though, in addition to the actual shipwreck, which was the human factor. We found 22 dead people in the bottom of the boat, and realized it was just, we had similar rescues where basically calm crowds submerged waist deep would manage to all survive, but, same actual shipwreck in another context where the crowd panicked and many people would die. So I think this video just demonstrates exclusively the crowd element that we're working on. Because it takes away the shipwreck element. This is kind of exclusively looking at the crowd factor. Again, I'm just looking at context. So I'll get rid of the audio, but very calm day there. No need for what's about to happen, but there was no coordination, no communication, no clear leadership, and the impacts again was higher risk than necessary of crushing in this event, as people kind of panic and jump. And MOBs. So again, exclusively looking at crowd dynamics. So I'm going to have a look at those risks a bit closer. So yeah, obviously the main killer. So again, why are people dying out here? The main killer was shipwreck. We're looking at various ways that kills people. As I said, MOB, people in the water, resulting in drowning, limited space, resulting in crushing, and panic also, like I said, increasing that crushing element. So we found these to be the main elements. Obviously, there's other things we explore, but they're very much not the primary cause of death. Obviously, the main cause of death here is just not being found in the first place. And again, our main impact is when we come upon a shipwreck that's actively happening rather than showing up after the event. Actually, the main impact would be getting it before it even happens. But in terms of people in the water and these kind of events, that's us showing up on scene as they occur. A couple other things to be aware of is often showing up on scene, we create panic, I think. That's because when you present an exit to people in distress, that crowd dynamic becomes charged. It can result in a magnet effect where you pull people towards the escape routes. that you present. That could be a life jacket or pulling your boat alongside, as we saw in that first video. And finally, like I said, if 75 kgs and 100 plus people, that's easily 7.5 tons plus on a boat. If you drag that across an unstable platform by presenting this escape route, it further destabilizes the boat and can make the situation a lot worse. So additional risks, again, that we're considering while managing these situations. Finally, it was very difficult to even see what was going wrong. Here's a boat in distress. There was already 5 people dead inside. We launched as per normal rescue, and we were ill-equipped to manage the risks that we faced. As such, we developed an assessment card to give us early warning and also guide our actions and make sure we approach with the appropriate equipment and planning to manage the problem. So I've talked about risks, I've talked about problems of assessment. Here's some mitigations. So quite simply, we started dealing with the causal pathway piece by piece. So you see, we've turned MOB into float. I think you can also see we turned panic into crowd control, so how we manage people, and limited space into removing people from the casualty vessel. Again, not definitive rescue here. We usually put them on life rafts or have very large working boats to manage that. And then actually managing the shipwreck is a huge element. So trying to make it a safer place for humans to be by removing weight. Again, if you remove 50% of people, that becomes a much safer platform for people to survive. We shift load away from dangerous areas, such as transoms of these boats. And then they often support parts of the sponsons that are deflated. And that actually is these are the kind of main elements we use to manage risk. Again, we need to understand that this is a dynamic, complex, and complicated risk environment. So often things that work one time won't work the next time. So as such, we've gone with a very kind of guidelines rather than prescriptive directions here. And what we try to do is support decision makers on scene with a kind of toolbox of options to achieve these various goals. So many ways of getting people floating, offloading people, or crowd control. You as a decision maker understand your various tools and the impacts they'll have and the negative elements they'll bring as well, and make good decisions as a result of that. So here's a tool we use, for example, that aids that kind of decision making. These are all our float interventions. We have more, but throwing life jackets, it's really fast. Instead of trying to pull people out of the water, we just get them floating by throwing them a life jacket. This is like 80 people in the water level decision making here. And then, disadvantages is you run out of life jackets really fast. People can jump off the boat at the life jacket. And also it's a short-term thing, because if they're weak, intoxicated due to fuel or hypothermic, that's not going to last long. And then we come up with mitigations for those weaknesses. So again, this is helping decision makers choose and act on the right mitigation for the right risks we're facing in these rescues. I'm just going to quickly buzz through this. This is a demonstration of our mitigations in practice. So we're approaching together as we know when we arrive, we'll create panic, and we want to have maximum capacity. These rafts are for offloading people from the target. The target has 4 of its 5 sponsons heavily deflated. There's only one place to offload people, which is there. We're going to start by life jacket distribution, but the additional volume of these life jackets on a crushing event can actually increase the crush risk. So what we're deciding to do is offload people. At the same time, we're going to send another boat around the other side to have a 360 assessment of the problem in case we need to adapt our mitigation process. Again, it's a dynamic process. Like I said before, you notice the heavy deflation here. This boat is very much ready to go. The transom's about to drop. We're doing crowd control here, pullbacks. So we close the escape route if we can't manage to control the crowd, because one person stepping on the sponson would have resulted in the boat flooding and likely loss of life. So that's what's going on now. We're doing 360 assessments, so sharing our game plan and assessments of the casualty vessel as we go. And here you see us offloading both onto our rib and onto our rescue rafts alongside. This is just to get as much weight off this as possible. And slowly you'll see the boat to be able to come up. Once the risk of crushing has gone down, we've offloaded people, we redistribute life jackets. That the boat's collapsed there. That's not a tilted engine. And here we are destroying the boat. So to aid this kind of decision-making, we decided maybe we could borrow from the RNLI and similar triage processes. And instead of looking at casualty care, consider the casualty to be the whole boat. For example, you consider a mass MOB event as being relevant or similar to a direct, life-threatening bleed. So let's look at the boat instead of individuals and manage the various events going on that boat as if we were managing, risks faced by an individual, and again, assess as per those risks. We started our first attempt at this was on the right there, and that's based on our assessment, mainly giving us an early warning signal for a mass casualty event. But we've moved on to this approach, which is kind of similar and inspired by the various triage elements we saw earlier this year, presented by the United Kingdom Coast Guard. So thank you very much for that kind of inspiration. We were working on this with Howard Ram historically from the RNLI as well. And again, this is outlining our best practice, our good practice. Again, this is an Alamo. This is a worst case scenario. If you don't have a more appropriate decision-making process, you can fall back on this, and your whole team is trained to follow this plan as well. So you'll work together well as a team while achieving it. And I don't think I have time to get into detail here, but the primary focus is getting people floating. Opportunistic recovery, we've had great success with resuscitation when we're on scene for the rescue event, from the shipwreck event. So in common practice, you're not supposed to pull people out if they're not moving and underwater. Especially with children, we've had a great success with that, with up to 7 children resuscitated in a single shipwreck. And indeed with adults as well, a bit less successful, but still worthwhile as long as we're not diverting our boat to achieve that goal. It's just if you're passing someone underwater. This is just not at all statistically backed up. This is experiential. Then we focus on the shipwreck and trying to stabilize that itself to make it a safer place for people still on board. Finally, we identify and evacuate at-risk people. I'll get into the detail there if there's any further questions. I guess I'm running out of time. A question I have for you is, would this be, what lessons in terms of risks are similar to other contexts, and what can be transferred and what can't? And again, we're aware that this is very much capacity specific to people operating in these environments, and are just curious. We definitely don't have the expertise or authority to make that assumption, but we're just curious to see if there's any crossover here to achieve the best possible outcome. And that's it. For me, that's a rescue boat that's also custom built for these kind of events. As you see, the resuscitation space is present. Over to you for any questions.